So we'll quickly finish up on the cephalosporins just by looking at these three main indications for meningitis. We can talk about the meningitis that is due to Pseudomonas aeruginosa. So in that case, you will use ceftazidime in particular. That would be the cephalosporin of choice in that situation. And if the meningitis is an acute bacterial meningitis, that is usually caused by Streptococcus pneumoniae. In that case, you would use clavulan. When clavulan is not available, then one can use Rocephin. Because it's difficult to get clavulan these days due to the decision by the manufacturer to basically stop making the drug. And if it's empirical meningitis in children, that is, the child comes in, you don't exactly know the causative agent. You haven't done a culture and sensitivity. You can just give a G3, either clavulan or Rocephin, and you can combine that with, say, ampicillin and vancomycin. And usually, if it's a child there, it's usually due to what we call HSN, H-flu, Streptococcus pneumoniae, and Neisseria meningitis. So those are usually what you will find in the meningitis in children. Sometimes Listeria monocytogenes can be involved, but it's mainly HSN that will be involved there. And of course, one can use that combination. Fever of unknown origin or sepsis of unknown origin. Those are usually due to gram-negative aerobic bacilli. And in such a situation, again, these two agents come to mind, clavulan and Rocephin. Those would be your cephalosporins of choice, and you can combine either one of them with an aminoglycoside. So again, it's a G3 plus an aminoglycoside taking advantage of the synergism that you can get with your aminoglycosides and beta-lactams. So that's what one will use. If it's not FUO or SUO, if it's just nosocomial infection, those are usually caused by Cape organisms or Capes organisms. Then, of course, you use Maxipin, Cefepime. And the last one we want to touch on there will be your human bat.
Dr. Mo, what's nosocomial?
Nosocomial means hospital,
Oh,
hospital acquired. The hospital acquired infections are usually caused by the CAPES organisms. And Maxipen will be the cephalosporin of choice in that situation. Human bite. Some organisms that you can extract from human bites infection is Streptococcus anginosus.
Excuse me. Now, when you say that, FUO and SUO, what do you really mean?
Fever of unknown origin or sepsis of unknown origin. Okay. Human bite, you can see this Streptococcus anginosus. That's usually the most commonly extracted organism from human bite. And then, of course, you will have your strep pneumoniae that can also be extracted, and then Staphylococcus aureus. And then, of course, you have Corynebacterium diphtheria, which is also usually extracted there. Ichinella corrodens, you can also see, and other species of Bacteroides. So those are the ones you will usually see extracted from the human bite, and for that you will use your cephomycins. The cephomycins will be the cephalosporins of choice. Next to the cephomycins will be cefuroxime. And then, of course, you can use a G3, either rosuvastatin or clavurin. So those are some quick things we want to say about your cephalosporins to complete that lecture. And that takes us to the end of the cell wall synthesis inhibitors.
Dr. Mo, when you say G3, do you just want those two drugs from G3
Those
or
are
everybody?
those are the G3s that are most often used.
Okay,
So,
but can you use the rest of the class?
preference.
The rest of the drugs that's in G3?
If it's within the spectrum,
Oh,
yeah. But the clavurin and your 7, those were the ones that we used as examples of G3 when we did the spectrum of activities.
Okay.
Yeah, because they're the most often used among the G3s, along, of course, with your 4-TAS, which is ceftazidime. Okay. So we come to the end of the cell wall synthesis inhibitors. And we can take the wall out. And once you get through with the wall, the next structure will be the cell membrane. And after you leave the cell membrane, you come to the cytoplasm, which is
protein.
where the protein synthesis will occur. So we're talking about protein synthesis inhibitors. inhibit cell membrane functions. You have your polymyxins there, and the pollines, that is pollen antibiotics. And you have gramicidin, which also affects the cell membrane. Novobiocin, you can see it as albamycin. It's another agent that can affect the cell membrane. We will of course take the polymyxins as the representative agents for drugs that inhibit cell membrane functions. Novobiocin is a very toxic compound, produces a lot of severe skin reactions, and so it's really not used often. And it inhibits, it has a very narrow spectrum. It just works on gram-positive organisms, particularly gram-positive cocci. But like I said, it's not used frequently because of that severe toxicity on the skin. So, but it works on cell membranes. That's all we're going to actually say on novobiocin. Gramicidin also works mainly on gram-positives. It works on gram-positive aerobic cocci and gram-negative aerobic cocci. So staph and strep, and then Neisseria species. So it works on GPAC, gram-positive aerobic cocci, and it works on GNAC, gram-negative aerobic cocci. So it is usually used in combination with other agents, and we'll see a very popular one in a second. So it also works on your cell membrane in terms of its function. And it's mainly administered topically in combination with cellular polymyxins. And we'll see that in a second. The pollen antibiotics are your nystatin and amphotericin B. And those are used more as antifungals. So we'll discuss those under antifungal drugs. Perhaps the most shall we say the grandfather of all your antifungal agents is amphotericin B. So we'll spend some time on that drug when we get to the antifungals. But they work also on bacterial cell membrane. So they are also cell membrane inhibitors. So the pollens will be discussed under antifungal drugs. So we're left with just the polymyxins. So your polymyxins are And you have two major types. You have polymyxin B and polymyxin E. Polymyxin B is also called aerosporin. That's the brand name for it. Polymyxin E is your colistin. And you have a methane sulfonate derivative of colistin. Which is colistin. So the one that we will take as the main agent to discuss will be your polymyxin B, which is aerosporin. Just says something about colistin and colistin. All right. So the polymyxins we said are true antibiotics, and they were obtained from some Bacillus species. The polymyxin B is from Bacillus polymyxa. You can see that organism also being referred to as Tynebacillus. So it's the same organism. Tynebacillus polymyxa is the same as Bacillus polymyxa, which is where your polymyxin B originally came from. And for polymyxin E, that was from your Bacillus colistens. And that's where you got the colistin from. Okay? It doesn't matter if it's your alarm or your phone, turn all devices off, okay, when class is in session. Okay. Now, the other agent that we had mentioned before that also came from the Bacillus species is your gramicidin, and that was produced by Bacillus brevii. Okay. So all these three that affect the cell membrane were actually originally extracted from Bacillus species. So we'll take aerosporin, like I said, as the representative drug there. And for your colistin versus colistin method, you have a difference in terms of the routes of administration. Your normal colistin is or can be administered PO and can also be given topically. And you see that in a product that is called colimycin S. Okay. So colimycin S has colistin in it. It also has neosporin, neomycin in it. And the S there just refers to sulfate. Now, the holistic method that you can give IM, you can also give IV, and may even be given IT. Okay. So basically, the simplest way to remember that would be your holistic method is administered parenterally, and your colistin is usually administered enterally. Okay, and the colistin method will come in colimycin M. And the M there refers to methane sulfonate. When you use polymyxin for the management of CRE, the polymyxin E can be used. But other than that, you just use them for ear and eye infections. So colistin can be used in your carbapenem-resistant enterococcal infections or enterobacterial infections. Which will be your gram-negative aerobic bacilli that are resistant to the actions of your carbapenems. So, in certain situations, you may actually even see that colistin given intravenously, but not very often. So the main thing we want to discuss then is your aerosporin or polymyxin B. And as usual, we go with source. So we already know the source. And then spectrum. Your polymyxins have a very narrow spectrum. They just work only against gram-negative organisms. Gram-negative organisms. Polymyxin B is effective against all gram-negative aerobic bacilli, with the exception of Proteus species, because it's not effective there. Providentia species, and then your Serratia. So polymyxin B is effective against all gram-negative aerobic bacilli, with the exception of these three. More specifically, we know that it is very good against Acinetobacter, especially the Bormanni. So another N there, double N. Acinetobacter Bormanni. And it is also effective against your Salmonella and Shigella. Okay. And against Klebsiella, and against your E. coli and your Enterobacter, and against Pseudomonas aeruginosa, and against Pastorella. So it is also effective against all of those very well. And then against your Bordetella. Bordetella pertussis, which causes your whooping cough. Okay. So it is specifically more effective against these ones, but it is effective against all gram-negative aerobic bacilli, with the exception of these three. Now, having said that, clinically, it is reserved because of its serious nephrotoxicity and neurotoxicity. It is reserved for severe Pseudomonas infections, Pseudomonas aeruginosa. Okay, so again, broadly speaking, it will be effective against all gram-negative aerobic bacilli, more specifically these organisms here. But clinically, in terms of using in clinical settings, it is reserved for severe Pseudomonas aeruginosa infections.
Is there like a certain route of administration that is specifically tailored to the neurotoxicity and the nephro?
Is there something that is tailored to?
Like, no, like the route of administration that's like tailored to it, like that associated with it. Like, you know, how to recommend 10 Gs, like the intrathecal associated with the neural, side effects. This one, what route is it supposed to be? Is it our route? Or specifically IM or IV?
We'll get to ADME in a second. Is that what you? Yeah. We'll get to its routes of administration. Okay. So we've done the source, and this is the spectrum, and this is the spectrum of antibacterial activity. And now the ADMA for that drug. Before that, we always do mechanism of action. So mechanism of action. The polymyxins, particularly polymyxin B, will bind to the lipopolysaccharide on the bacterium, and then will react with the phospholipids on the cell membrane. They act like cationic detergents or surface active agents. So they're like cationic detergents. Because the surface of the organism, the membrane, surface of the membrane of the organism is usually negatively charged. And so you can have a negative positive reaction. So they are like cationic detergents. And by reacting with those phospholipids, then they would create channels or holes in the membrane of the bacterium. And if you do that, then you will have a leakage of the internal medium of the organism. So the internal medium of the organism will leak out. And then the bacterium would, of course, be killed. So So that's the way polymixins work. And when cationic detergents, they bind to the LPS, lipopolysaccharide, and then they will react with the phospholipid of the membrane. And they will create channels or holes in the membrane. Internal medium of the bacterium will leak out, and the bacteria will die. So they are bactericidal agents. Okay? And they give you a concentration dependent bactericidal effect, just like your analogs of vancomycin.
I was about to say dapamycin.
mentioned. Yeah.
Is it kind of like dapamycin?
Yes, daptomycin, dapavansin, oritavancin, terivancin.
So can we say this would cause myopathy?
No, not
No.
necessarily.
Okay.
So that's the way polymyxin B would produce its antibacterial effect. Now we go to the so if you're keeping tab, you know vancomycin will produce time-dependent bactericidal effect. Your beta-lactams, that is, those stage 3 inhibitors will give you time-dependent bactericidal effect, while the one that works on the membrane, polymyxin, will give you a concentration-dependent bactericidal effect. And a little bit about this admin. And with admin, we always start with the route of administration. For aerosporin or polymyxin B, you can give it intramuscularly, and you can give it intravenously. It can also sometimes be given intrathecally. It can also be given intravenously. And it is also administered PO, sometimes, and then topically. If it's to be given parenterally, that is by injection, the IM route is the preferred route of administration if you have to give it parenterally. Okay. And when it is given IM, it is administered with a local anesthetic, Procaine. So you give it with like a 1% solution of Procaine. Procaine is here, right? Okay. And that would reduce the incidence of pain at the injection site, and it would also reduce the incidence of tissue damage at that injection site. So if you want to give it by injection, IM is preferred, and when you give it IM, you give it concurrently with 1% Procaine hydrochloride, which is a local anesthetic agent. In terms of its half-life, it is about 6 hours in terms of its half-life. Nothing much to say about its biotransformation.
What about the black one right there?
That's even worse. So, nothing much to say about is biotransformation, and in terms of the excretion, it primarily undergoes renal excretion. And if there's any sign of renal failure or renal damage, you either don't use Aerosporin or you reduce the dosage drastically. Aerosporin is one of those antibiotics that can be expressed in units. 1 milligram is equivalent to 10,000 units. And you usually give about 15 to 25,000 units. Per kilogram per day of that drug when it's used parenterally. So that's the ADME. In terms of its indications, you use Aerosporin in, like I said, Pseudomonas aeruginosa infections that are resistant to penicillins or to cephalosporins, okay, or even to aminoglycosides. So severe infections caused by Pseudomonas aeruginosa, which has become resistant to penicillins, cephalosporins, or aminoglycoside. That's when you use your polymyxin. 2, just like your colistin, which is polymyxin E, you can use polymyxin B in the management of CID. And it can also be used for the management of ear and eye infections, particularly again when caused by your Pseudomonas aeruginosa. For instance, if you have corneal ulcer, ulcer of the cornea, that is caused by staph, you will prefer to use bacitracin. But if the corneal ulcer is caused by Pseudomonas aeruginosa, then it has to be Aerosporin or polymyxin B. So you have some preparations that, of course, contain your polymyxin B or your Aerosporin. Some of them we've already talked about before, but polymyxin, neomycin, dexamethasone, that's what you have in that very popular drug, Maxitrol suspension. So that can be, that will be topical. So you can use it in the eye and you can use it in the ears. So polymyxin, neomycin, and dexamethasone. Of course, we've mentioned your cordyceps before. So that'll be like your PNH, polymyxin, neomycin, hydrocortisone, right? And then you have your Neosporin, and we've mentioned some of the combinations there also. So you can have polymyxin, neomycin, and gramicidin. gramicidin that we mentioned earlier. Okay? So that would be like in the suspension form, or you can have neomycin to do the ointment, and that would be PND, polymyxin, neomycin, bacitracin. Okay? And then polysporin. Polysporin, you have your polymyxin that can be given also with that gramicidin. I think this will work. Okay, thank you. Try that. So the polysporin will be polymyxin with your gramicidin. And you can also have this will be the solution or suspension, that you have polysporin ointment, which will be polysporin with bacitracin. Okay. So those are some that you can come across. We mentioned another very common one, polytrin. We break that down. The polymyxin with trimethoprim. Trimethoprim. That would be your polytrin. Now that's another preparation that combines polymyxin with a tetracycline, oxytet, oxytetracycline. So that's not as commonly used as all these other ones. So those are some preparations of your polymyxin that can be used topically for ear and eye infections. In terms of the adverse effects that we can get with that drug, you have just two major adverse effects that you have to be concerned with when you are using your Aerosporin. One is the nephrotoxicity. That's a very commonly encountered one. That's why the drug is reserved for severe infections. If you want to give it for systemic use. So nephrotoxicity. The manifestations of the nephrotoxicity can include an elevation of the BUN, blood urea nitrogen, and one can also say something like oliguria and anuria. And proteinuria. And some casts in the urine, which will mean there's a damage to the epithelial cells of your renal tubules. If you see cellular casts in the urine. And then azotemia can develop. And then you can eventually get the most serious one, uremia, in which case you send the kidney is already damaged. People make an error of they're confused about exothermia versus uremia. Okay. There's a major difference between those two situations. Exothermia just means you have an elevation of nitrogen in the bloodstream. So it can come from your ammonia, for instance. It can come from your uric acid. It can come from creatine. It can come from creatinine. It can even come from urea. It can come from creatine, creatinine. So it just means you have elevation of nitrogen levels. When exothermia results in the expression of signs and symptoms of damage, that's when you have uremia. So when you have physical signs and symptoms resulting from this elevation of nitrogen levels, that's when you actually have uremia. And the manifestations there can be in terms of the GI manifestations. So you have non-specific GI conditions. Can be in form of the pulmonary system. So the individual might have difficulty in breathing, okay, or they might even develop apnea. And another manifestation can be on the muscles. So you have muscle weakness, muscle paralysis, and that can result in the paralysis of the muscles for breathing. And so they can get that apnea. And sometimes it's CNS related. They can have seizures, they can have dizziness, disorientation. All of those can be manifestations of exothermia resulting in uremia. And the symptoms, when they exist, that's what you would call, the condition we refer to as uremia. So that's the difference there. And I always try to emphasize that letter A in creatine. Okay. Because if you leave the A and E out, what you get is creatine. I was invited to a little presentation by someone, and the presenter was saying creatine, and he actually meant the creatine. And I just looked around like, who is he insulting? You know, because creatine, somebody who is uncouth, you call them a cretin. Expand your vocabulary.
Don't worry, Google will tell me the definition.
Dr. Mo, really quick, so the difference between azothermia versus what?
Now she found out what cretin is.
Explain the stupid person.
If somebody is uncouth, if they are awkward, if they're what you call an oaf, you know what that is?
Okay,
If you
Google.
call somebody an oaf, or if you call somebody a boob, it's not a boob you're thinking about.
Okay, that means
Yeah.
I'm cultured.
Or if you call somebody a robe,
A foolish person.
you know.
These are all British names.
All
by
of
the way.
those are related to cretin. So I'm looking around like, why is he insulting people?
A country bumpkin. That's what the last one is. Don't play with that.
No, for okay. So the azotemia, so is it just without the signs and symptoms?
Who's a rustic? Okay, what's your?
Wait a minute, you're coming up with all these words that I ain't never even heard
Don't
of.
worry, Google's my friend.
The azotemia, is it without the signs and symptoms?
Right.
Okay.
So
urine is
azotemia,
some-
you just have that elevation
Mhm.
of the nitrogen basis, or nitrogen.
Oh.
Okay.
You see?
So then
But
what
when
puts it in the difference between BUN then, BUN? Because that's elevated of nitrogen levels too.
yeah, but blood urea nitrogen, that mainly comes, you really mentioning nitrogen that comes from urea in particular. Azotemia will be nitrogen that comes from everything, you know,
Okay.
yeah.
Gotcha.
And then when that produces signs and symptoms, we call it uremia.
Are you arrested? What is it?
It means from the countryside. Yeah, that's it. So I remember seeing a board. Now that board is better, but it's smaller.
It's all right.
But it's smaller.
And then you have neurotoxicity that can be produced by that drug. Another major adverse effect. And the manifestations can just be like your muscle weakness, or person may experience ataxia, numbness, irritability might be another manifestation. They get drowsy. And then they can experience what you call circumoral paresthesias. Circumoral paresthesia, as you can see, also referred to as perioral. So in other words, numbness around the mouth. And that is very easy to detect. And then you can get some neuromuscular blockade. And this neuromuscular blockade, of course, can affect respiratory muscles. And that can then lead to a paralysis of those muscles of respiration. And the patient can then have apnea or severe interruption of respiration. So those are all manifestations of the neurotoxicity caused by polymyxin. So if you're talking about nephrotoxicity, then in terms of drug-to-drug interactions, you know you can interact with, say, vancomycin, okay, because you'll get additive nephrotoxicity. You can interact with methicillin. You know, methicillin is highly nephrotoxic, you know. And then with your aminoglycosides, which is the next group we're going to discuss. So you can have that interaction there, neurotoxicity. If you give polymyxin concurrently with an aminoglycoside, you can also get additive neurotoxicity. Okay. So, and leave the cell membrane and get into the cytoplasm. We can talk about the protein synthesis inhibitors. Alright. So we're now inside the cytoplasm. And what happens there? You have your protein synthesis. And so we go back to pre-kindergarten, where you discuss how protein is synthesized in the body. Your double helix DNA, right? Your DNA has a double helix structure, which just basically means it points like that. So the DNA unwinds, and you have a single strand of DNA, and then you have a complementary copy of the DNA that goes on inside the nucleus. And so you get your mRNA, messenger RNA. The messenger RNA goes to the cytoplasm, goes to your ribosomes, and that's where you have your other RNA, which is rRNA, and that's what? Ribosomal RNA. Okay, and it will bind to a 30S unit on your ribosome. And when mRNA goes out to the ribosome, it has the codon. That's a triplet, right, of your of your base plus sugar plus phosphate. Okay. That is nuclear base, then plus your sugar, which is either, in this case, would be ribose, and then with a phosphate. Okay, so that would be a nucleotide. So you have 3 nucleotides, because they come in 3. That's your codon. So the codon is 3 nucleotides. And that's what the mRNA brings to the ribosome. And then you have the 3rd RNA, which is what? The tRNA, transfer RNA, that's already present in the cytoplasm. The tRNA now brings what you call anti-codon to that site where mRNA has already bound to your ribosome. Okay? So tRNA will know where to bind based on the codon. So the base pair, will be opposite. So where tRNA binds depends on the codon, that is the nucleotides that are there. And the tRNA, of course, has or carries an amino acid that goes to that site. So when it binds, you have an amino acid present there. You repeat that process, and you have molecules of amino acids binding to each other. Of course, that will be your foundation for your protein. Because when you have amino acids binding, you get protein. So that's essentially how your protein is synthesized. And when we interrupt any of those steps, you can interrupt protein synthesis. So your protein synthesis inhibitors can be classified either based on the mechanism of action, which basically means whether they bind to the 30S ribosomal subunit or to 50S ribosomal subunit in the bacteria. The ones that bind to your 30S ribosomal subunit are your aminoglycosides and your tetracyclines. Okay. And so we say for 30S, drugs or PSIs, that is protein synthesis inhibitors, that work at 30S, all you need to remember is that. That's the sign for what? At. At is what? AT. There you go. So those are the ones that bind to 30S, ribosomal subunit. And the ones that will bind to your 50S will be, many of them, your macrolides, your ketolides, your lincosins, that will be lincomycin and clindamycin. Okay, these are called lincosins. Here, your other agents that would be like synacid would also bind to, or we have this 50S ribosomal subunit. Zymox will also work at the 50S ribosomal subunits.
Are they their own class or are they like actual drugs other than macrolides?
Okay. It depends. Your ketolides, you only have one drug, ketek, but it's still a class. The ketolides used to be, all of these ketolides and lincosins used to be classified as macrolides. But then further studies show that they're slightly different, and so they were separated out. The synacid will come under streptogramins. That will be the class, but as we see, synacid has 2 streptogramins in it. So when we discuss the streptogramins, we'll mention those. Okay, so that's one way of classifying them. Another way is using the spectrum. So you have some that work primarily on gram negatives. You have some that work primarily on gram positives. And then you have some that are a broad spectrum, that can work on both gram positive and gram negatives. Okay. And I should use the word primarily, because it's not just gram-negative, but primarily gram-negative, primarily gram-positive, and then the rest that can work on both. The ones that work on gram-negatives will be your aminoglycosides. Aminoglycosides work primarily on gram-negative organisms. The ones that will work on gram-positives will be your macrolides, pyrrolides, and leukocytes, okay, and even your streptogramins, that is synacid, and your Zyvox or linezolid, all of those can work primarily on gram positives. And then the one that can work on both will be your tetracyclines. There's a drug called chloramphenicol, very, very useful, and is still commonly used outside of US. That's like a lifesaver in typhoid fever. It's not used here anymore, but anywhere else you go, this is a major drug, chloramphenicol, and it works both on gram-positive and gram-negatives. All right, so we'll use the you didn't get the one that what? The gram-positive will be all of this. Yeah.
Do you mind spelling out that S word, the one that he said, streptogranule, whatever?
Streptogramins, that's a class. That's streptogramins.
Okay.
Synacid actually has 2 streptogramins in it. And currently it's the only drug in that class that is used clinically. It's the only one. Okay. Zyvox belongs to this class, Zazoridinas. So we'll talk about all of this as we go along. That's like an analog of Zyvox that also belongs to this group. But, we'll discuss that as we go along. So we're going to use the functions to classify the agents. So we'll start with your aminoglycosides, and then we'll talk about the tetracyclines before we move over to the 50S side. So the aminoglycosides are also true antibiotics, and they have certain things in common. One, they are very polar compounds. They're very polar compounds because they are amino sugars that are in glycosidic linkage with the hexose moiety. So they're very polar compounds, they have a lot of hydroxyl groups. And because of that, they do not cross the biological membranes regularly. Okay. So they're not easily absorbed through the GI tract. There are 3 of them that are administered orally. And even though they're given orally, they're not given for systemic purposes. They're given for an effect on the GI tract. Okay, not being absorbed into the bloodstream. Neomycin. Neomycin is one of them that you can give orally, but not for systemic infections. Okay. Another one that you can give orally is your paromomycin. Paromomycin, and then of course your kanamycin. So neomycin, kanamycin, and paromomycin, those can be administered orally, but not for systemic infections or systemic purposes. If you give an aminoglycoside orally, it is mainly for managing what is called hepatic coma. Okay? The plural for coma is not comas, it's comi, okay? Because it's a Latin word. Okay? So plural for coma is comas. And hepatic coma is actually, we would not expect you to say hepatic coma anymore after today. We would expect you to say PSE. Okay? Since you're talking about the liver vessels, okay, portal systemic encephalopathy. That's where hepatic coma is, PSE. And what's the main manifestation of PSE? How does it occur? You have a build-up of ammonia in the blood. If you have a high concentration of ammonia in the blood, it is transported to the brain, and then it affects the brain. It damages the brain, so you have that encephalopathy. So it's mainly due to too much ammonia in the bloodstream. Okay, that's a very commonly used drug called lactulose. Lactulose is mainly used also for PSE. Okay. It can be used for managing constipation at low doses. Okay. But for instance, if you see somebody taking 1 teaspoonful or teaspoonfuls of lactulose, that's just for treating constipation. Because lactulose is nothing but a bunch of sugars. Okay? So you give the sugar, it attracts water to the lumen, and that will flush the system. So that low dose is used for constipation. But if you see somebody taking 1 ounce or 2 ounces of lactulose, you know, even up to 3 times a day, then you know they have hepatic coma, which is your PSE or portal systemic encephalopathy. But an aminoglycoside administered orally can always be used for your hepatic coma management. So other things that are common to your aminoglycosides. Site of action, because they all work at the 30S ribosomal subunit. They are all bactericidal. And they give you concentration dependent bactericidal activities. Concentration dependent bactericidal activities. And we said sometimes when people get habitudinous, they try to oversimplify an issue, and in doing that, the habitudinous activity makes them give you an incorrect information. You've heard people say, well, if it inhibits cell wall synthesis, it is bactericidal. If it inhibits protein synthesis, it is bacteriostatic. You see right here, that is not true. Okay? Aminoglycosides inhibit protein synthesis, but they are all bactericidal. That's not the only proof. If you look at your macrolides, erythromycin inhibits protein synthesis. It is usually bacteriostatic, but at a slightly higher dose, it can be bactericidal. Okay? Your clindamycin can also do that. So that broad generality sometimes results in incorrect information. So that's one thing that's also common to the aminoglycosides. They can all give you that residual, or what you call post-antibiotic effect. In other words, after you expect their antibacterial effect to have been over, they continue to cause death of bacteria. Okay? And the realization of that made people to start using a QD administration. See, before we knew about the post-antibacterial effect of aminoglycosides, like say your gentamicin, your tobramycin, it used to be given on a TID basis, Q8. But after the discovery of the residual activity, you can take what would have been given total. When you give that TID, you can give it just one a day, or once a day, and that will still give you the therapeutic effectiveness you're looking for. So they all have that post-antibiotic effect. They are all nephrotoxic, neurotoxic, and autotoxic. With different levels, different stages. And some of them have been compared in all these three major adverse effects. For neurotoxicity, mainly talking about neuromuscular blockade. Okay. And so they're all allotoxic, neurotoxic, and nephrotoxic. And they all tend to go out in the urine, okay, urinary excretion, primarily unchanged. So that means whenever you use an aminoglycoside, you have to be conscious of the kidney function. Because if the creatinine clearance goes below or goes to like 30 and below, then you have to definitely change the dosage of your aminoglycoside. And they are all ineffective against your anaerobes. They are all ineffective against anaerobes, and they all work mainly on your gram-negative organisms. The aminoglycosides can have a minor effect on staph and strep, but you don't use an aminoglycoside for a staph or strep infection alone. If you ever see them used where you have a staph or strep infection, it is usually in combination with a beta-lactam. So you take advantage of the synergism with those drugs. So those are all things that are common to your aminoglycosides. So we'll take the aminoglycosides together, since we said the, well, let me put it this way. Gentamicin is the main one we will discuss, okay? And gentamicin is almost as commonly used as your tobramycin. So those are the top two aminoglycosides that you can see used. We said they are true antibiotics, so there must be a source. And you notice that there's a difference in the spelling. Gentamicin is M-I, okay? It's not M-Y. Gentamicin is M-I, not M-Y, or like your kanamycin or tobramycin and so on. The difference there is because of the source. If it's M-Y, it is produced by a Streptomyces. And if it's MI, it is produced by actinomycet. Particularly Micromonosporin species. For instance, gentamicin is produced by your Micromonospora purpura. And that's how you got your gentamicin. And sometimes the source also gives you an idea of the brand name. If you have Streptomyces Fregi, and you take that with that, you can get the brand name for your neomycin, mycifredin. Mycifredin. That's one of the used by, and that's one of the brand names for your neomycin. You know, Streptomyces canamyceticus. That's how you got kanamycin. Streptomycin canamyceticus. That's the source of your kanamycin. And so we have myces and cana. And what's the myces? Kanamycin, and so on. The source of this pyromomycin is also the source of a tetracycline that is called oxytetracycline. So Streptomyces rhamnosus is the source of pyromomycin, and it's also the source of oxytetracycline. So those are just some examples there to show you that your aminoglycosides are true.
So 1 to 13, each of them have a source?
We can go through all of them.
No.
No, they all have, you know, a source. And that's why I said if it ends in IC instead of Y, then it is from an actinomycetes, like that micromonospore. So they are all true antibiotics. And for spectrum, again, mainly gram-negative, aerobic, never an anaerobic. Okay. And when we go through the indications of the gentamicin, you see some specific agents there. Mechanism of action, you already know that. They will just interact with the catalase ribosomal subunit and inhibit protein synthesis. Okay, ADME, if we're taking gentamicin as a representative agent, the ADME will always start with the routes of administration. So you can give gentamicin, IV, IM, IT, and you can give it topically. Okay. There's a liposomal preparation of gentamicin that is called Mytec. Okay, and that is used primarily for the treatment of the Big Mac. That's Mycobacterium avium intracellular complex. Mycobacterium, that's the N. The A is avium. The C there is cellulare and then complex. So that disease is caused by a complexation of two mycobacterial species, Mycobacterium avium and then Mycobacterium intracellulare. And that is a very hard infection to deal with. You find it mainly in immunocompromised individuals, particularly your AIDS patients. It's one of the common causes of death in AIDS patients. So in that situation, we use the liposomal preparation of gentamicin. Septopal is also a little different. Septopal uses some impregnated beads. So you impregnate or soak some beads in gentamicin, and that is placed on like a surgical wire. And it's then transmitted into the muscles and then to the bones. And so Septopal is mainly used for osteomyelitis that is recurrent. So if you have severe recurrent osteomyelitis and you want to use an aminoglycoside, it will be gentamicin, and that's how it will be administered. It will be the Septopal formulation that you will use in that situation. So, and of course, gentamicin can be administered topically, because you can use it for things like skin conditions like, say, some burns, and impetigo, eczema. So it can be used for those situations when it's administered topically. And you also have eye infections, ear infections that you can use gentamicin for, and with the topical formulation of the drug. In terms of its distribution, because it is highly polar, it doesn't cross the biological membrane regularly, so it is excluded from the cerebrospinal fluid. But even with that high polarity, it still crosses the placenta barrier. So it can actually get across the placenta. And that's one of the reasons why your aminoglycosides are classified as category D when you're talking about pregnancy. Okay. D as in David. But it gets distributed very well into the peripheral spaces. For instance, you can get it into the peritoneal cavity very easily, or into the pleural cavity, into the synovial fluid. It gets distributed into the synovium, sputum. It gets distributed in there. So it can go into all those spaces, but it does not get to the cerebrospinal fluid regularly. The half-life is taken to be 2 to 3 hours. But if you have renal dysfunction, then that can increase significantly. So if the renal system is functioning very well, the half-life is about 2 to 3 hours. plasma protein binding is negligible, very, very low. So you see that even though it has low plasma protein binding, it still does not cross the blood-brain barrier, mainly because of its polarity. Okay. And in terms of the excretion, there's nothing to say about metabolism. And so in terms of the excretion, it is excreted mainly through glomerular filtration, so to the renal tubules. And we've talked about the relationship with creatinine clearance. If the creatinine clearance goes low, you have to decrease your gentamicin dose. So that's in terms of
Dr.
this.
Mo, so this right here is in terms of distribution?
Right,
Okay,
yeah, it goes into all these fluid spaces.
and
Yeah.
no metabolism?
No metabolism, but it goes out mainly through
Green.
the renal system. A little bit can go out through the breast milk. Okay, so that also adds to why you categorize it as a category D in terms of when the patient is present. Now, that goes really for all your aminoglycosides. Like we said, they all get excreted almost unchanged through the renal system. So you always have to look at the creatinine clearance whenever you're giving your aminoglycosides. So that's the ADME. We'll skip the indications for now and just quickly finish up today with the adverse effects for your aminoglycosides.
Can you please repeat the half-life? I know you said.
2 to 3 hours
For the normal.
when the kidneys are functioning properly. But if the creatinine clearance goes to like 30 mils per minute or below, the half-life will be increased, which means the drug is not excreted from the body.
Thank you.
So adverse effects of your aminoglycosides, using gentamicin, of course, as a specific example. I would mention some of them: the ototoxicity, nephrotoxicity, and then neuromuscular blockage. Okay. So we'll come back to those three, but there are other adverse effects that you can see. For instance, malabsorption syndrome. Malabsorption syndrome, you see that mainly with neomycin. This is number 3. So neomycin is the aminoglycoside that is most likely to give you malabsorption syndrome. Neomycin is also the one that is most likely to give you that increase in fungal growth in the GI tract, that is supra or super infection. Super or supra infection. So that can then lead to pseudomembranous colitis. Okay, so neomycin is the one that is most likely to give you that. Scopolamine is a particular adverse effect that you can see with streptomycin. That's like a blind spot in the eye. Okay. So streptomycin is number 7. Is the one that is most likely to give you that scopolamine. And peripheral neuritis is also that streptomycin. It's the one that is most likely to give you that peripheral and of course some people are hypersensitive to aminoglycosides, so that can be with any one of them as a possibility. Now, do the other toxicity. If you're talking about your ears, you have two functions, right? Vestibular and then your cochlear. Vestibular and cochlear functions, that is balance versus hearing. Okay? Your aminoglycosides can affect both balance and hearing, but to different degrees. For instance, neomycin, or people will be neomycin a lot of the time. Tobramycin can affect both of them almost equally. That is balance and hearing. Okay. You look at a drug like gentamicin and a drug like streptomycin. Okay. Those two tend to affect balance more than hearing. Okay. They tend to affect balance more than hearing. And then kanamycin and amikacin, and then your metilmycin. Kanamycin, amikacin, and metilmycin, those tend to affect hearing, that is cochlear effect, more than your balance. Okay. Once that ototoxicity occurs with an aminoglycoside, it is essentially irreversible. You will have it for a very, very long time. Unlike nephrotoxicity, where once you discontinue the aminoglycosides, kidney functions can come back to normal. With ototoxicity, it is long lasting. Okay. So, and some of them have been compared against each other as far as ototoxicity goes. We know that neomycin is the worst offender. Okay. So it can always happen when it comes to ototoxicity. Gentamicin would essentially be next. And then your tobramycin, amikacin, and streptomycin. So that's the order in which they are likely to produce ototoxicity. With your nephrotoxicity, okay, you basically have your kanamycin and gentamicin being about the same, and then tobramycin and streptomycin. So streptomycin is the least likely to produce ototoxicity or nephrotoxicity. Okay. And the pattern repeats itself with neuromuscular blockade. Neomycin is always the worst offender. Streptomycin is always the least offender. Okay. And whenever you have that neuromuscular blockade, you can reverse it by using a calcium salt or by using your cholinesterase inhibitors like neostigmine, neostigmine, hydrophonium chloride, that's one of them. You probably went through all of this. And your ANS. Okay. So neostigmine, pyridostigmine, don't use phosphostigmine. So all of this can help to reverse the neuromuscular blockade of your aminoglycoside. So if a child is to be given an aminoglycoside, you always have to have calcium gluconate or some calcium salt by the bedside before you start giving that aminoglycoside, because otherwise the neuromuscular blockade can lead to the paralysis of the breathing muscles, and so apnea results, and the little child can have an unfortunate outcome. So that's what we have for the adverse effects. So on Monday we'll talk about indications of aminoglycosides and then move on to tetracyclines. Questions?
For the neomycin, is there a particular, because we're talking about whether it's focused on balance or appearance, the neomycin, is there one that's more?
Neomycin can do both, but it is more on the vestibular thing, that is the balance issue. That's called okay. You won't get much of that, of course, if you give it orally. Remember, it doesn't get absorbed into the system.
Like approximately how long do you use it to get this
How long does what?
How long do you use it to get?
Oh, to get the ototoxicity, or okay. Only one single dose can actually give you that ototoxicity. Only one time. Okay, and sometimes you can use it for like 3, 4, 5 days, nothing happens, and then 6th day you give it and it occurs. You know, and here's another factor about the ototoxicity. You may use it, you get out of the hospital, the last time you used it was 3 years ago, and then it happens. And it's, you know, it's hard unless you have the patient's profile to trace it back to the aminoglycoside. So there's no rhyme or reason to it. You know. Okay.